Now I invite Dr. SURISHTI Raj sir for giving a talk about this refractory GDD in uveitic glaucoma, because uveitic is also there's difficult situation. Sometimes the patient can have hypotony, then some high IOP. Following the surgery, also very high chance for even chronic hypotony.
Good morning to all. Thanks to Dr. Faisal and organizer for giving me an opportunity to present my talk. I have no financial interest. So, I'll be talking about GDD of choice in refractory uveitic glaucoma. So, these are the various indications for drainage devices. So, today I'll be talking about uveitic glaucoma. Apart from these, this can be done as a primary stent also. So, what are the challenges we face in glaucoma surgery in uveitis patient? So, uveitis reduces the success rate of glaucoma surgery, more likely to scar and fail, and there is more chance of hypotony, and it can flare up the inflammation, and it can also initiate or worsen the cystoid macular edema, and high to low syndrome due to recurrent uveitis cycle. There can be ciliary body inflammation and ultimately leading to atrophy. So care must be taken in planning and timing the surgery to minimize the risk and maximize the chances of success. So there are two mechanisms of glaucoma: closed angle due to synecdoche or pupillary block or neovascular glaucoma, or open angle seen in steroid responders, or clogging of the TVM with cells, fibrin, or inflammatory debris, or chronic trabecular meshwork damage and scarring of the outflow channels. So pre-operative consideration should be given a consideration. As far as possible, wait for inflammation to settle or it is minimal. Maintain intraocular pressure on dimarcs for few weeks for inflammation to subside, especially when the optic disc is also not bad. Add oral and topical steroid 1 to 3 days prior to surgery. If the patient is steroid responder, you can add topical non-steroids also. In case of viral uveitis, add antivirals 1 to 3 days prior to surgery. So, what are the options we have in uveitic glaucoma? So we can do external stents or trabeculectomy. Lasers and cytophotocoagulation are usually not considered. So, intraoperative considerations: avoid multiple entries into anterior chamber and minimal and gentle handling of iris or uveal tissue. In case of synecdoche, prefer large CI so that it is not blocked tube and is not blocked by the iris tissue. Since the conjunctiva is friable, so it's better to use non-tooth forceps, and also there is fibrosis. So there may be difficulty in making the dissection. So take care of scleral flaps. So there is no button holding. You avoid tooth forceps and avulsion and cheese wiring of the suture used. And at the end, make it sure that there is no to avoid hypotony. There should sutures should be tight, and if AC is shallow, make sure that you leave some viscoelastic into the AC. So basically, the steps of the surgery are same as in any routine GDD, but some of the pre-op consideration which I discussed should be taken into consideration. Make a liberal flap, and as far as possible, use the non-tooth forceps or hold the tooth forceps, hold the tenon with tooth forceps whenever possible, and take care that there is no button holding of the conjunctiva. And usually we prefer the same quadrant, that is temporal quadrant, unless there are fibrosis and synecdoche, then you can go for spironasal also. And after creating the flap and deep pockets, we can place the plate. In case of this is the what I am showing, this is the AGV implant. This is placed between superior rectus and lateral rectus muscle. Since its width is small, in case of Vadi, you have to place it under the wings are placed underneath the superior rectus and lateral rectus muscle. The rest of the steps are same, but since it is usually associated with synecdoche, and in pseudopekic patient, you can place the tube at the side of previously CI or in the sulcus, but make it sure that the end of the tube is visible. So, in case of anterior synecdoche, make a large uh, CI so that its end is visible and also it is not blocked post-operatively by the iris tissue. So post-op period is also very critical in case of uveitic glaucoma. So aggressive anti-inflammatory drugs are used in post-operative period to control the inflammation. It's better to give a IV bolus of the steroid immediately in post-op period, and frequent topical steroid used with tapering and titrating against the amount of inflammation. Also use the non-steroidal anti-inflammatory for prophylaxis of the CME and give strong cycloplegics. So in case of, if the patient is already having steroid implants, post GDD inflammation may be less, but there is some delay in wound healing that may be impaired. So late wound healings can be expected. So as far as choice of GDD is concerned, these are classified based on the type of the plate or type of the material or type of the opening. So it can be rigid or flexible based on the type of the plate. A material can be of silicon or polypropylene, and tube can be valvular or non-valvular. So GDD, this is the chronology development of the all the implants, Molteno, then Krupin, then Barbell, then AGV, and last was the Adi, which is basically the prototype of the Barbell only. These are the various designs of the various devices used. So we can expect complication. So hypertensive phase that is seen more with the AGV or valvular implants, and there can be transient hypotony varying from 12 to 26% of the cases, but most of the time it settles down. Other complication can be encountered like end of migration of the plate or tube erosion. Diplopia is usually seen with barbell, almost 9% of the cases. So success of the implant varies from 17 to 79%, and maximum success is seen with Molteno DP plate. Other approaches, trabeculectomy can be undertaken in case the stent is not available, but SLT and DLCP are usually not considered because they themselves mm, uh, create inflammations. So these are some of the problems with TRAB, why it is not prevalent in inflammatory glaucoma, early failure, post-op infections, or shallow AC or choroidals. So this was the retrospective meta-analysis done by Ramdas et al. Efficacy of GDD in uveitic patient was compared against the GDD in non-uveitic patient. So the intraocular pressure control was similar, only the macular edema and hypotony were seen slightly more in uveitic GDD, though this was not significant. And this finding also corroborated with the previous reports. So in conclusion, GDD in uveitic patient, success rate is almost similar to the non-uveitic patient. Hypotony is slightly more than the non-uveics, and cystoid macular edema is also more than the non-uveics. Control of inflammation prior to surgery is very important and crucial to the success of the tube. And minimal iris and uveal tissue handling during the surgery. And consider large PI if there is a lot of synecdoche. And if pseudophakic patient, we can consider the placing the tube in the sulcus. Aggressive anti-inflammatory therapy in the post-operative period is mandatory. Thank you.
Thank you, sir, and for wide elaboration of the management of uveitic glaucoma.